Well, good day, everybody. This is Chris, and what I'd like to do is I'd like to go over some homework real quick, and this is going to be the anion gap and osmolol gap toxicology exercise that my students had to go through. So I just want to go through it and make sure everybody's looking good and on the same page. So let's go ahead and start off the first beginning of the scenario. So the segue is upon arrival, you find a 22-year-old male experiencing tonic-clonic activity, so he's having a seizure. He's supine on the emergency room stretcher. An IV has been placed. A nurse practitioner is present and asks you what should be done. And that brings us into question number one. And question number one asks, please identify the name. Okay, so we need to identify the name, the dose, and the route of the medication that you would order in this situation, assuming there are no contraindications. Okay, so it says there in the question, there are no contraindications and you have to order. So this is somewhat ambiguous because there are several ways to look at this, and the two primary ways that I'm looking will involve the agency of a single class of medication. So first of all, the first part of this question is you have to identify that the frontline medications that we use for controlling seizures include the benzodiazepines. Include the benzodiazepines or the benzos. These, of course, act upon GABA receptors, or receptors for gamma-aminobutyric acid, which is a transmitter in the central nervous system that acts as a ligand for the GABA receptors, which are ionotropic, or rather, they are chloride channels. They are ligand-gated ion channels, allow chloride to flow into the cell, and that effectively depresses the neuron. It makes it much more difficult for the neuron to depolarize because the electrical potential is more negative. So in essence, these medications help enhance the effect of GABA, and that's why we go for benzodiazepines. And as you may know, there are some xenobiotics, such as isoniazid or INH, which actually decrease the ability for the body to produce GABA, and we know in those cases benzodiazepines may not be effective for those kinds of seizures, but in a situation like this where we have a limited amount of information, we still will typically go for the benzodiazepines as our frontline medication to control these seizures. So the two medications that I was really looking at was either looking at the longer acting benzodiazepine lorazepam. So I'll write that. Lorazepam. And I was looking for a dose of about 1 to 2 milligrams. And we would be giving this IV. I believe it says that IV has been established. If there wasn't an IV, maybe IM or even establish interosseous axis if an IV was difficult to establish in this case. The other medication that would be acceptable would be diazepam. Diazepam, which is a little shorter acting than lorazepam, and you can look at a dose between 5 and 10 milligrams. Again, can be given IV, IO, or possibly IM if you had no other option. The trade name for lorazepam, you should know this is Ativan. All right, Ativan, and the trade name for diazepam is Valium. All right, so that's question one. So then it moves on and it says, following the intervention above, the seizure stops and the patient is having deep snoring respirations. His SpO2, that's his pulse oximetry reading, is 88% on room air, but the breathing appears unlabored. There's no vomitus in the airway. And then so question number two asks, what interventions are we going to perform now? So really what's going on here is that we have an airway issue, and hopefully I was just hoping that people would identify the presence of an airway issue. There's the snoring respirations. All right, so you've got the tongue falling back in the airway, and we know that the tongue is the most common cause of airway obstruction in the unconscious patient. And then I deliberately put in there that there was no vomitus in the airway, just to let you know, hey, there's nothing that you really need to do suction-wise. So at this point, the primary things I was looking for was for positioning. Okay, we don't really have enough information to know whether or not this is traumatic. So if you went ahead and said you'd go with a jaw thrust, that'd be okay. Head tilt, chin lift would be okay as well, because there just really isn't a whole lot of information about what was going on here. Because this scenario is associated with the toxicology, obviously there's an assumption that's what we're looking at. But either way, I was looking for positioning of the airway. You probably want to consider an adjunct as well, either a nasal or an oral airway. Either would be okay. Of course, oral airway could elicit a gag reflex. Nasal might be a way to go here. And then you're going to want to provide oxygen. All right. There's a couple of ways that you could have stated how you do this. Maybe you'd open the airway, insert an adjunct, and then apply something like a non-rebreather mask, 15 liters per minute, and see how the SpO2 looked. Some people may have even gone, hey, let's go ahead and assist ventilations. And either way would be fine, because there really isn't enough information at this point to know whether or not we needed to, what is the respiratory rate. It just says it's deep and snoring. Is it 2 times a minute? Or is it 20 times a minute? You really don't know. So either way, I would allow. I was just really looking to see if you were thinking that really aggressive airway interventions at this point be indicated. Okay, so then we move on down. It says a bedside BGL. Okay, so a blood glucose level. So this is a point of care test has been done, and it reads 89 milligrams per deciliter, and hopefully you guys would recognize that as a normal finding in non-SI units. The patient has no significant medical history, but friends report he has been depressed following a breakup with his girlfriend last week, and an empty bottle of Bayer. Okay, so let me write that out here. I should put little trademarks here, I guess, so I don't get myself in trouble. There we go. Bayer, and I put that in quotes as well, was found next to the patient in his bedroom. And then we go into question number 3. It says labs have been drawn and indicate the following. So we have a whole bunch of data here. So this is my ABG, 7.29 is the pH. The CO2 is 36 millimeters of mercury. The O2 is 102 millimeters of mercury. Bicarb is 14 milliequivalents per liter. Chemistry, Chem 7 or Chem 12. We'll assume that an SMA 12 has been done because there's some additional information, but I didn't give you the whole thing, just the relevance. So let's see, we have a serum sodium of 142, chloride of 100. These are all in milliequivalents per liter. A potassium of 5 milliequivalents per liter, a blood urea nitrogen of 18 milligrams per deciliter, glucose of 100 milligrams per deciliter. So these are non-SI units. And we also did an ethanol level, or an ETOH, which is 0. And then we also performed a measured serum osmolality, which is reading 350 milliosmoles per kilogram in this patient. And it asks, what's the interpretation of the ABG? Okay, and do the labs support the supposition of a Bayer overdose? All right, a Bayer overdose. Okay, so that's question 3, a whole lot of information. So let's just go ahead, and I always like to start at my gas. So I'll look at the ABG, 7.29, that's clearly acidic. 36 for the CO2 is normal, actually. 35 to 45 is the normal range. 102, 80 to 100 is normal, so it's a little higher. And I'm assuming that this is a little higher because we placed them on oxygen here, bagging, or assisting ventilations in number 2, so that's okay. and then 14 for the bicarbonate, 22 to 26 being normal. That's clearly acidic. So then I just kind of connect the dots here. I notice that my overall pH is acidic. It is the bicarbonate that's causing it. So that is a metabolic. So we will put metabolic acidosis. All right. And then we just need to identify whether it's compensated or not, or partially compensated. And because this is the only area where I would see compensation right here, because this doesn't really count, it's normal. If it's normal, that means there's no compensation. So this is a uncompensated metabolic acidosis with normal oxygenation this time. All right. So far, we're looking good, and so far we have a pretty decent case for bear overdose because we do, in fact, have a metabolic acidosis. Well, let's just talk about bear. Hopefully, you should know that bear is a generic term, or a trade name, rather, for ASA, or acetyl salicylic acid, which is aspirin. Okay, and we know that aspirin causes metabolic acidosis, but aspirin that often causes an increased respiratory rate, and so I would actually almost anticipate at least a partially compensated metabolic acidosis. So far, the information I have is somewhat conflicting. But is there something that we can do to kind of zoom in on the diagnosis? And hopefully you guys recognize that there is in fact something we can do. And anytime we identify the presence of a metabolic acidosis, we need to ask ourselves, what is the anion gap? Is it normal or is it elevated? And the anion gap is simply electroneutrality. And we just take the major positive players, that's our sodium, and we add that to the potassium. Some people don't use potassium, but we've been using it. And then we subtract from those guys the major negative players, the chloride and the bicarbonate. So let's just go ahead and plug the numbers in. So my sodium here is 142, my potassium is 5. Okay. So that's 147 total. My chloride is 100. My bicarbonate is, go back up here, 14. Okay, so that gives me 114. Okay, so 147 subtract 114. Let's do that. So that's a 33. So my anion gap is 33 milliequivalents per liter. That is clearly elevated. That is substantially elevated. So we have an elevated anion gap metabolic acidosis. And if you remember the things that cause, the common things that cause, they fall into that mud piles mnemonic. So there we go. That's methanol, uremia, diabetic ketoacidosis, parahaldehyde or propylene glycol toxicity, INH or isoniazide toxicity, lactic acidosis. This is salicylates here, and E is ethylene glycol toxicity. Salicylates include things like aspirin, bismuth salicylate, Pepto-Bismol, those kinds of things. So in fact, salicylate toxicity is on our differential. So far the information does support the hypothesis of a bear overdose when we marry that with prior history. Okay, so let's go ahead and move on now. I'm going to have to move on to an extra page. So question number 4, let me just change the color here. So question number 4 asks, do you suspect co-ingestion of a possible toxic alcohol? Okay, toxic alcohol co-ingestion. All right. Now, there are several what we call the alcohols, and alcohol of course, just has to do with a chemistry side group that makes things alcohols. But these include things like ETOH or ethanol, methanol, ethylene, glycol, propylene, glycol, not really, and then isopropyl alcohol. Isopropyl alcohol. Now, ethanol is not generally considered a toxic alcohol, even though it is toxic. It's just that these guys have very specific toxicities associated with them that are very severe and have very acute um, and immediate consequences that we need to be worried about. And I should say that these toxic alcohols are typically not toxic by themselves, in themselves. They're kind of what we call a prodrug, where they don't actually become toxic until they are metabolized into what are known as toxic metabolites. All right. And typically what happens is the enzyme alcohol dehydrogenase or dehydrogenase is involved in that chemical reaction of metabolizing these into their toxic metabolites. And so we know that treating them can often involve administering medications like fomepizole, which can inhibit the ADH enzyme and prevent it from metabolizing these into their toxic metabolites. Additionally, we used to use ethanol to treat toxic alcohols because the ethanol is also metabolized by ADH, and if we can give you enough ethanol to, in essence, compete for the action of ADH, then these guys here may not be metabolized as aggressively to their toxic metabolites. But fomepizole tends to be what we run into. Okay, anyway, all that aside, the question is, does the information support toxic alcohol co-ingestion? And the question is, really what I was looking at is there something else we can do with the labs to kind of give us a little better case for going, yeah, I think that it is reasonable for me to look at a toxic alcohol, and of course that's going to be the osmolol gap. The osmolol gap is essentially what it is. It is just the difference between the measured and the calculated serum osmolality. So here I have the measured serum osmolality of 350 milliosmoles per kilogram. So the osmolol gap is just the measured less the calculated. And we normally want that around 10 or so. So I've got my measured, so what I need to do now is I need to calculate the osmolol gap. And this is, of course, where we have to use that terrible serum osmolality formula, because we've got to find our calculated. So let's just go ahead and review that real quick. So the calculated serum osmolality looks at our major players again, and these include things like sodium. So my sodium, and then I have to multiply that sodium by 2. Okay, so there's my sodium. And then I add that to what? Well, I go to my next major player, my urea, or in this case that would be my BUN, my blood urea nitrogen, and I divide that by another coefficient, 2.8, plus the glucose, which is my third major player, and I also have to divide that by another coefficient, which in this case will be 18. And if we had the ethanol level, we could even compensate for that. We could take the ETOH and divide that by 4.6. So I should put a plus there. So if we go back to our labs, let me just select a different color here. So if we go back to our labs and look at our labs, so remember our sodium was 142. Okay, so 142. My blood urea, or my blood urea nitrogen, is 18 milligrams per deciliter. My glucose was 100 milligrams per deciliter, and my ethanol level is 0. So we can go ahead and rule out ethanol, and all we have to worry about are the three major players here. So I take sodium, multiply it by 142, BUN, the 18 divided by 2.8, 100 divided by 18, and then I add all those numbers up. Okay, so I was thinking that I wouldn't do this, but I figure, you know what the heck, let's just I'll go ahead and throw the answer down there for you guys. And that answer ultimately comes out to be about 296 milliosmoles per kilogram. Okay, so now that I have my calculated, I can go back, and my measured was 350, and I'm going to subtract from that 296, my calculated. Let's do some quick rearranging here. That's 4. That's 5, and that gives me a gap of 54. It's much higher than 10. So an elevated osmolol gap does indicate the presence of a toxic alcohol. So we are fairly well justified in saying that we would want to assume a possible toxic alcohol co-ingestion. Okay, now moving on to question number 5. And question number 5 says, aside from drawing ASA or aspirin levels, salicylate levels, would you also want to check the serum APAP? APAP is the abbreviation for acetaminophen. Okay, and we know that Bayer is aspirin, it's not acetaminophen. So would we still want to obtain acetaminophen levels? That's really what it's asking. And then why? Well, hopefully everybody answered yes. Yes, absolutely I want acetaminophen levels, because acetaminophen is generic for things like Tylenol. It's very easy to get a hold of. It's over the counter like aspirin. It's can often be used as a co-ingestion. We know that this patient probably already overdosed on aspirin. It's reasonable to be suspicious of other agents being on board. Acetaminophen is a very common agent. It's very easy to get a hold of. It's commonly overdosed on. And just like aspirin, we have the ability to run acetaminophen levels and check them very easily at most traditional labs. This is not a specialty lab or a send-out lab. So it's quick, it's easy, and it gives us high yield information. So absolutely, we should be drawing that, and that should really be a part of virtually all toxicology workups: aspirin, acetaminophen, ethanol levels. In addition to blood chemistry and possibly an ABG, depending on what's going on. We'd also look at the EKG as well, because these are things that should just kind of happen as almost a standard of care, if you will. Okay, and then last but not least, question number 6. Question 6 says, would you want to administer activated charcoal? So it's asking about activated charcoal. Explain why you would choose to either administer or not administer this for GI decontamination. GI decontamination. All right. So do we do it? Do we not? Well, acetaminophen, aspirin are agents that may be helped by activated charcoal. But with activated charcoal, there's some caveats. The first caveat is it needs, really for it to work, it needs to be a substance that it can absorb, first of all, or it can bind. And second of all, it needs to be within 1 hour. Really, we look at within 1 hour of the ingestion. And then the second criteria is the airway. Okay, is the airway secured? Is the patient alert, awake, oriented, and able to actively protect their airway? In this case, the patient isn't. The patient is altered. He has altered mental status. We've had to take measures to open the airway, so the airway is certainly not secured. Now, if you had said something about intubating and placing a gastric tube, then you might be a little better justified in administering charcoal, but we still have this 1 hour here. We have an unknown time frame. So at this point, it would be very difficult to justify gastrointestinal decontamination based on the information that I've given you guys. Okay, guys, I'm going to go ahead and wrap it up. Hopefully you found that helpful, and we will see you next time around. As always, thanks for hanging in there, guys.